Good afternoon. My name is Martin Leon. I'm going to be your anchor person for this symposia, and I want to introduce you to our spokesperson, Dirk Scheinert from Leipzig. The title of this symposium is Sirolimus-Coated Balloon for Coronary Artery Disease and Peripheral Artery Disease Treatment, The New Frontier. This meeting is sponsored by Concept Medical. We have wonderful discussants, and they represent some high levels of expertise in both coronary and peripheral vascular disease, and they are Sandeep Basavaraja, Antonio Colombo, Bernardo Cortese, Ahmed Mohsin, and Alex Abizad. This is going to be an interesting symposium because we've blended or fused some of the experiences in both peripheral arterial and coronary artery disease. There are three main goals of this symposium. The first is really to introduce you to the clinical trial program that is being used now for the MagicTouch Sirolimus-Coated Balloon for the treatment of both coronary and peripheral arterial disease, and will be selective in pointing out specific clinical trials that are underway to make certain points. To try to give you a better understanding how the sirolimus-coated balloon behaves clinically and also from a technology standpoint compared to what has been previously the gold standard, which has been paclitaxel-coated balloons. And also to give you experience from cases, either case studies or also a recorded case from experts to really help you to understand from a procedural point of view, what are some of the tips and tricks of how to select patients and how to implant these devices successfully. So with that as an introduction, we're going to begin with our first speaker. We'll have lectures, recorded cases, we'll have selected discussions, and we also hope that we can keep the audience animated enough that they will participate as well and ask questions. Our first speaker is known to everyone in the endovascular space, Dirk Scheinert, and he's going to talk about the results from the first head-to-head comparison of sirolimus versus paclitaxel-coated balloons in peripheral arterial disease. Dirk?
Well, thank you very much for the very kind introduction and the honor to present here at this symposium. I'm going to show you in the next minutes the results of the first head-to-head trial which we have in the peripheral space, looking at the novel sirolimus-coated DCBs versus the more established paclitaxel coated DCBs. The name of the trial, which is one of a very comprehensive clinical trial program supported by Concept Medical, is the so-called Sirona randomized clinical trial. It was set up as an investigator-initiated trial led by my co-PI Ulf Teichgräber and myself through the University of Jena in Germany. It was a prospective, randomized, controlled, multi-center trial trying to demonstrate non-inferiority comparing the sirolimus-coated with the paclitaxel-coated DCB in femoral popliteal artery disease. And it was I'm going to show you the primary objectives then in a little bit. Here you can see the trial scheme. In total, 482 patients were enrolled. So for a peripheral trial, a relatively decently sized trial, one-to-one randomization was carried out. There were some slightly uneven numbers due to block randomization, but you can see that roughly 240 patients were entering each group, and there was a reasonable retention out to the 1-year time point. So what again was the rationale for setting up this trial? Well, clearly paclitaxel, these DCBs have been shown to be effective in femoral popliteal artery disease in several randomized clinical trials and in registries. However, there has been concern, I'm sure you followed this, in the last years around paclitaxel safety. It was a signal of increased toxicity in terms of increased mortality, which let's say with more complete data sets was not sustained, but there is some discussion still remaining also on about local toxicity and so on with paclitaxel. Sirolimus, as you all know very well from the coronary field, is a very established anti-proliferative and immunosuppressive drug, which might be a very promising treatment option. Well, this trial, I just want to show you some highlights of the patient characteristics. So the vast majority of the patients in the trial were claudicant patients with either severe or moderate claudication, relatively few patients with rest pain. The trial enrolled lesions up to 20 centimeters of stenosis or occlusion length in the femoral popliteal artery, which is rather long. So the mean lesion length was 8.4 centimeters in both groups. You can see 34 or 32% respectively were total occlusions. And there was a high proportion of patients with quite severe calcification scores reported. So there was certainly beyond the typical cohorts, I would say a moderately complex lesion cohort. You can see here the procedure characteristics. In about 1/4 of the patients, more than one DCB was used. Post-dilatation was, to optimize the result, was performed in about 1/3 of patients, and bailout stenting for focal lesions was carried out in about 20 to 25%, which is also in line with other previously reported trials. What about the study endpoints? The primary efficacy endpoint was very similar to other comparable trials. Primary patency was assessed by duplex ultrasound with a PSVR with a peak systolic velocity ratio of less than 2.4 as a threshold, and absence of target lesion revascularization at 12 months. And the safety endpoint was a composite of clinically driven target vessel revascularization, major target limb amputation, and device or procedure-related death. For both endpoints, we used a non-inferiority margin of 10%. So you can see here the primary effectiveness endpoint, primary patency at 12 months. Clearly, there was a very little difference of only 1% between the two groups, and the p-value for the non-inferiority statistical test was 0.019. So this endpoint was successfully met, and also the primary safety endpoint was successfully met. You can see here the difference between the groups was roughly 2%, mainly driven by clinically driven target lesion revascularizations or target vessel revascularizations as depicted here. There was just one incidence of major amputation in each group, no death reported. So this slide shows also the clinical curve, let's say the clinically driven target lesion revascularization, or better to say the freedom from clinically driven target lesion revascularization, which was not statistically different out to the 12 months time point. What about clinical improvement at 12 months? We can see that overall around 90% of patients in both groups showed a clinical improvement of at least one Rutherford category. There was an observation that for the paclitaxel DCBs that was somehow a bit more pronounced, which we don't know yet if that is a realistic finding or just a played by chance, but it was noted here in this trial. If you look at other clinical outcome measures, hemodynamic improvement typically measured as ankle brachial index, you can see that both groups had a similar benefit. And also statistically, that was not different. In terms of walking distance, you can see that at 1 year, the pain-free walking distance was improved slightly more in the sirolimus group, 211 meters improvement compared to 190 meters. And the maximum walking capacity was also improved in both arms, statistically, no differences. And also, if you look at the quality of life score, both patient groups showed comparable improvements. So in conclusion from that trial, we can say that this first head-to-head comparison of paclitaxel and sirolimus-coated balloon showed comparable results between the study groups in terms of primary patency, in terms of safety, and also in terms of freedom from clinically driven target lesion revascularization. There was a similar clinical improvement, slightly more pronounced in the paclitaxel DCB group, The walking distance was not statistically different, but was improved in both groups, and also was vascular quality of life. Well, as I mentioned, this is the first important trial coming out of this peripheral trial program. Initially, it was planned that Professor Barco would also give an update on another very important and interesting study, which is just about to analyze their data, and I was asked to give a few slides on the SIRPAD trial. The SIRPAD trial is another investigator-initiated trial out of the University of Zurich, led by Dr. Barco. And in principle, it is very much a randomized all-comers study. So inclusion-exclusion criteria were very open. In principle, everybody who underwent endovascular angioplasty for a lesion of more than 50% diameter, a symptomatic lesion of more than 50% diameter reduction was eligible unless the patient would participate in other studies. The patients were here randomized to the sirolimus DCB compared to plain balloon angioplasty, which particularly in Switzerland is still the standard of practice. And while in reality, also in general, we are missing still some clinical information also from the paclitaxel studies. Randomization was done 1-to-1, stratified for patients with critical limb ischemia versus patients presenting with claudication to just ensure a good balance here. The primary endpoints are looking, as I said, on clinical endpoints. The primary endpoint used for the study is a composite of two different major adverse limb events, which is unplanned major amputation of the target limb and endovascular or surgical target lesion revascularization for critical limb ischemia within 1 year after randomization. The authors intend to perform a statistical analysis basically based on a hierarchical approach. First, they are looking on the non-inferiority for the primary efficiency outcome within 1 year, and if that would be confirmed, which of course is the hope that sirolimus-coated balloons would at least perform non-inferior to plain balloon angioplasty, then they want to test superiority for the composite of unplanned major or minor index limb amputation and any target lesion revascularization, and then on the second level, superiority for the primary efficacy endpoint, absence of target lesion revascularization. What about this? Again, shows the study flow. So basically, a study which carries out clinical follow-ups out to 5 years, simple 1-to-1 randomization. There was an interim analysis pre-specified in the protocol after 600 patients being enrolled. That was also done because the trial was studied still in the middle of the paclitaxel discussion, so there were no worrying signals so far reported. The overall primary outcome was slightly higher than in the statistical analysis. However, the study was conducted and they achieved their target number of 1,250 enrolled patients. So for cardiologists, this is a typical number. For us in the peripheral field, this is still quite an achievement and probably the largest randomized clinical trial in the field. And so the data are currently analyzed. You could see enrollment was completed beginning of this year. So there will be interesting data coming up in the future. Thank you.
Dirk, that really was a fascinating presentation with two very different and both important studies. We have, again, a very expert panel. So first, let me pose to our panel members if you have any questions of Dirk regarding either of these trials. Well, as you're all thinking, let me ask Dirk just a few questions. I like the fact these were investigator-initiated studies. So these were studies that are really done by clinical scientists who are really trying to get the right answers. So I think having these as investigator-initiated studies that are supported by a sponsor, I think is very powerful. The first study, Sirona, to me is extremely important because we need to metric these newer devices using a different agent, sirolimus, versus paclitaxel. There has always been this concern that it would be difficult to get enough sirolimus into the vessel wall for long enough to achieve a biologic effect that would be as significant as paclitaxel, especially in peripheral vascular disease. So are you convinced, Dirk, that based upon this non-inferiority assessment, that as best as you can tell, with a fairly comprehensive analysis out to a year, that these two devices are clinically equivalent in femoral popliteal disease?
Well, that's an interesting question, and of course it's probably not possible to draw final conclusions because this is just one randomized clinical trial. And also the inclusion criteria were really relatively open compared to many other initial pivotal randomized trials done with paclitaxel devices in terms of longer lesion lengths allowed, more CTOs enrolled, more calcified lesions enrolled. Of course, it does not cover the full spectrum. I mean, there is still a need to study really very long occlusions, highly calcified vessels, and so forth, which will be done to some extent. Also, it is done in CERPED. But I think based on what we've seen, at least, we can say that based on the typical effectiveness endpoints, which is primary patency, which has been used in all other trials as well, and we've seen here a non-inferior result with a good, let's say, statistical foundation in a solid patient population. And yeah, I think for me this is kind of reassuring that we are on the right way with the device, and future research should be carried out.
Well, two interrelated questions. First, one of the concerns, as you mentioned in your introduction with paclitaxel, is that there have been some safety considerations. When would you expect those to express themselves in a clinical outcome trial like this? Is 12 months too short a period of time to examine the safety of a DCB?
Yeah, absolutely. And so I think the 12 months endpoint is probably just appropriate to get an initial feel on the effectiveness. Even for the effectiveness, it will be interesting to see the 2-year data and then also look at the longer time curve. But for assessing the safety aspects, I think we really need to look at a 5-year time span, because also in these meta-analysis, which initially raised the signal of increased toxicity and increased mortality, that was happening after 2 years, and so 2 years and beyond. This was when these curves tended to separate slightly. So yeah, we need to see these long-term data. Of course, we need to see these data in much larger cohorts. So eventually, we will not be able to test, to answer this question, whether sirolimus has benefits in that regard based on 500 patients. We need more patients. But for the time being, I think this is still, let's say, a very decently sized trial, and comparing to, let's say, what the typical, process was, that we started with proof of concept trials, with looking at late lumen loss as an angiographic endpoint, and then going to slightly larger, like first in men trials. This, I think, was a very solid approach, and I can only emphasize that I think that was also unique to Concept Medical, that before they were pursuing the typical FDA IDE trials, they were already supporting physician-initiated trials like the Sirona trial. So that gives us the opportunity to already have some preview on what might be coming out of future, trials which are also ongoing.
I guess I'm trying to tease out some things from these trials, and I'm learning that in endovascular trials, it may be that the later follow-up data is extremely important, and we should pay attention, of course, to the primary endpoint at a year, but it may be equally important to look at the 2-year data, the 3-year data, just to look at recurrence rates and other safety considerations. And along those lines, of course, with all of these trials, these were complex lesions. You had some were greater than 15 centimeters and heavily calcified. Do you have any sense that the mode of recurrence is any different in the paclitaxel versus sirolimus? And by that I mean either diffuse restenosis lesions or focal restenosis lesion. Do you have any insights that there may be a different pattern of restenosis?
Not yet. Quite honestly, we haven't, finalized this analysis in detail. But let's say on the first view, we've seen similar patterns in these restenotic cases. What's going to be very interesting in the longer term is to look also on local toxicity. I mean, this has been a concern in some of the peripheral applications. We are using quite frequently atherectomy devices, particularly to remove eccentric plaque or calcified plaque, which may sometimes result in deeper cuts into the adventitia, and there have been reports of aneurysmal degeneration after such combination treatments in some cases. There have been also reports of a so-called halo phenomenon around drug-eluting stents in peripheral arteries, which, is not fully understood, but might be due to a local inflammatory response. So we hope that, let's say, sirolimus might be a more benign drug, maybe a bit better applicable also in such challenging scenarios. But this is also something what we will probably need to the 2 years data to get a better understanding of that.
One last question.
Yeah, one last question. Thank you so much. It's a great presentation and a great data. Now, obviously, I don't do coronary work. Peripheral work. I mainly work on coronary arteries. And when we have tortuous lesions, we find it sometimes deliverability is an issue with paclitaxel. I know you use very long balloons in peripheral intervention. Do you have any of those difficulty delivering these balloons, especially long paclitaxel as compared to sirolimus?
You mean problems in which regard?
Yeah.
Deliverability?
Yeah.
Well, I would say in general, particular in the femoral popliteal space, which is the mainstay of where we use drug-coated balloons for the moment, deliverability is not the biggest issue, because we have relatively big arteries. All these arteries are pre-treated with predilatation or other methods, so deliverability is typically not an issue. But if you're asking for of course, there are differences in the coatings amongst different brands of paclitaxel balloons. Some are more rough, some are more, let's say, sleek and slippery. That may have. Sometimes that's, sometimes the sleek coatings do not get the best delivery results. At least that was the experience with paclitaxel. I think here with sirolimus we have a completely different scenario because we have a nano-encapsulated drug on the surface of the balloon, which by itself is a very sleek type of coating with a very minimal profile. So deliverability is absolutely not an issue here with these new devices.
What about the positive remodeling between the two groups? Positive remodeling.
Sorry?
Positive remodeling in case of DCB and sirolimus and paclitaxel group, both group. Any evidence or experience? Yeah.
Aneurysm formation, remodeling, positive.
Remodeling. Okay.
Yeah.
So no, here in this let's say analysis so far, we haven't seen any differences. Here also, of course, the lesion complexity was, as I said, moderate. and we did not use, let's say, atherectomy devices for pre-treatment. So this would be something which should be done in, let's say, in larger trials or registries, and then we need to look at this combination effect. I think the issue is also in the paclitaxel world, we're only coming up in really combination treatment patients for very complex disease. Here in this trial, we haven't seen a difference yet.
Great. Well, I think we're going to stop here and go to our next presenter. Dirk, thank you again. So Sandeep has a recorded case presentation where he'll show some of the observations that he's had having treated, I would say by now, thousands of patients with drug-coated balloons.
Thank you very much. It's a great honor to be part of this meeting and symposium, so thanks for the invitation. So can I have my presentation? There we go. Okay, so I've got following conflicts of interest to declare. So my objective of this session is to show a case from a real-world practice and show some important tips and tricks when doing DCB angioplasty and discuss when is an acceptable result post-DCB and when to perform bailout stenting. So with this, let's go straight to this case. So 68-year-old lady with crescendoangina symptoms in the background of type 2 diabetes mellitus on tablets, ex-smoker, hypertension, and dyslipidemia. Her echocardiogram showed good LV function, and the stress scan showed ischemia in the inferior and the lateral wall of the left ventricle. So the angiogram was done subsequently, and as you can see, the left main is okay, and LAD is a mild disease. And clearly you could see there's a very tight stenosis in the mid-circumflex involving a large bifurcation. And you could see some collaterals to the right coronary artery from the left system, and as expected, the RCA was a CTO. So we have a blocked right, a significant disease in the circumflex, and LAD, some mild to moderate disease. So the strategy, obviously, we thought the RCA was the dominant artery, and we have to perform the PCI to the RCA first, and then bring it back and do a stage PCI to the circumflex. So I'm not going to go into the details of the CTO procedure. Essentially, it was antegrade wire escalation with a microcatheter and a Gaia wire. And you could see there is a wire in the conus branch with some balloon to offer some balloon anchoring to spin the corsair. And obviously, we made some progress, and we checked with the contralateral injection, and we caught the true lumen with some manipulation. And following this, we spun the corsair, exchanged a workhorse wire, ballooned IVUS, and then we deployed 2 drug-eluting stent. So this is post-DES, and you could see there is a diffuse disease in the distal RCA extending to both PD and PLV branches. Normally, I would treat this with a DCB, but because the patient had a disease in the circumflex, we decided to stop here because we had spent quite a long time opening this artery. So I would say if anyone stop at this stage, normally I would do because obviously I want to see the actual size of the vessel because the flow dynamics gets better and the vessels remodels even without any intervention sometimes. So it stops unnecessary intervening on the artery when it's not needed. So 4 weeks later, we saw her in the clinic, and she had a marked improvement in her symptoms, but still had residual angina. So we brought her back 8 weeks later for a repeat intervention. So plan was to take some diagnostic shot of the right coronary artery and treat it if necessary, and also treat the circumflex. And we went with the 7 French sheath and a guiding catheter. We took a more supportive guide, like an Amplatz guide. And it was done by myself, one of my colleague consultant, Dr. Bhatia, and one of our fellow, Dr. Keder. So this is exactly 10 weeks since the index procedure. Can we get the volume? Maybe the volume is... So we have a volume speaking in here, so we may have to...
The PDA for sure. Possibly also into the PLV.
Yeah.
This is not
Let me
uncommon
flip
in
on the
our,
beginning, so probably you lost the
voice.
right coronary artery. Okay. So if you show 2 pictures back, you see the artery has grown. Do you agree, Gubir?
Definitely. There's disease extending into the PDA for sure. Possibly also into the PLV.
Yeah.
This is not uncommon in our work, that we would leave these alone to defer the distal vessel intervention, giving the vessel a chance to grow.
Yeah.
But I think we also commonly treat these sorts of lesions with drug-coated balloons. So I think this is a good example.
Yeah, because we want to avoid putting a long layer of small stents in the PD and PLV branches. I think you're right. And if you show 3 pictures back. Okay, so that was the setup shots. So we have this kind of disease. So I just want to kind of pause here and ask the panel and anyone in the audience, how would you treat this? What is the strategy? So whether you go for stents, and if so, it's a provisional stenting or 2 stents. And if you go 2 stents, DK crush, cool out, tap is not ideal because of the angle being more acute, or would you consider DCB? So any comments from
I can start from here. So I think this is a perfect indication for DCB. You already treated, the proximal portions with after CTO occlusion with a lot of metal. So then the vessel starts to be smaller, diffuse with bifurcation. So there is, of course, we would jail the side branch. So I think for all the reasons in the world, I would try a DCB first.
Yeah, Sandeep, first of all, you did, in my opinion, a good choice in not treating it immediately after the CTO. This is what we usually do when we have a diffuse disease, and here you also have a bifurcation, so I think it's wise. The other thing, I would not pick any of these, because as you know, I would just prepare the lesion and then decide, because in the end you may change your strategy. With DCB, the advantage is that you decide at the end, after you have prepared the lesion.
Dr. Sandeep?
Yeah.
It is good to wait for a few days because vessel may grow up after CT opening. So if you do the functional test or FFR, after you saw this for functional test, FFR, this time to see any significance of lesions, distal flow?
That's a good point. No, we didn't do any functional assessment here because, my concern at the time, the index procedure was that probably we are underestimating the size of the vessel. Maybe it is not. But when we re-imaged, and clearly there is a diffuse disease, so no, we didn't do any functional assessment here.
I mean, I guess that could have been an option to do functional testing to decide if you needed to do anything to that distal right system. I sense that something would need to be done, knowing that you're going to need to treat the circumflex, because that certainly seemed to be a very significant lesion. It might not have been unreasonable to try physiologic testing of that distal right.
Yeah. So I think, Bernardo, you made a very good point. I think this is very, very important. You may want to use DCB, but the decision is made after the lesion preparation, because if you have a recoil or a flow-limiting dissection, which means clearly you cannot use DCB, you may have to go for a stenting. So it's very, very important to make that difference, that you cannot commit for a DCB unless you prepare the lesion. So obviously for the pre-dilatation, we have plenty of balloons. Now, I normally start with a conventional balloon, which is a NC balloon. And I tend to take 1-to-1 balloon to heart ratio because I don't like going with 1.5, 2 or 2.5 upsizing, because you're doing multiple inflation, multiple damage to the vessel. So take a 1-to-1 balloon to heart ratio, especially if you can pass the balloon. And more importantly, take a longer balloons, because that will avoid, again, multiple inflation, and keep the balloon for at least 25 to 30 seconds when you do a pre-dilatation. And don't worry about the ST segment elevation, because patient will have ST segment elevation, will have some chest pain. You may have to give some medication, pre-medication for that. But most importantly, look for the blood pressure. If the blood pressure is stable, you can leave the balloon. Now, so just go to one of the tips we recommend is using a longer balloons for DCB than taking a shorter balloons, and always use an NC balloon than a semi-compliant. That's debatable because there's no kind of data comparing the two, although we reported a retrospective data where there was more dissections with the semi-compliant balloon. So this balloon has tracked nicely, you could see there. So go on a little bit. Do you think that's okay? Yeah, so I'm just going to do a dry cine run. So you'll see we use very less contrast. You'll probably see in the next few minutes. Okay, let's go up there gently. So we're going up. So Linda, you may get some pain when we do this. So we tend to inflate the balloon for at least 25 seconds. So the timer is on. You can focus on the hemodynamics. You could see that obviously STs may go up. But we feel that by doing this, we are doing two things. One, the less recoil because we're getting prolonged inflation. Second, it kind of induces ischemic conditioning, so which means when we inflate for 1.5 minutes, they won't feel it down.
So that's an active-pulse balloon, and it's a subnominal 10 atmospheres.
So then we'll go slightly higher up in here, which is right on the stent. Yeah, can go up here. So this will go a bit higher up. Flow store, please.
That's 13.
So timer on again. So we'll do again another 25 seconds. So far we've not seen any ST elevation. Now maybe we've done the proximal. Maybe she'll get it. Any pain at all, Linda? Not yet, yeah. So everything's going well. We're just inflating the balloon. So there is some slight ST shift you could see in lead 3 especially. Lead 2 and lead 3, yeah. So that's very normal. Any pain? No, she's not in pain, although there's some ECG changes. So generally the ECG changes precedes the pain. So we're done here with this. So we're going to take this out and put this in the PDA. So this is very commonly seen in DCB angioplasty because with the stents, we do very short inflation. With the DCB and pre-dilatation, we tend to bit longer. That's one of the tips and tricks we use. And so you could see now this is a used balloon, but it's tracking nicely. So I think that should, because we don't need to go that deep in the PDA, isn't it? So PDA is only, this is, in fact, even come back a little bit. Yeah, so happy there? Yeah, so we're going to go up here. Another 25 seconds timer on, please. So this is gone up slightly high. So we'll, yeah, ECG is normalized. Now we can go again. Again, timer on, please. So one thing we have noted with the DCB angioplasty, you've got some ectopics, so just pull the wire back just in case one of them is irritating.
So that's 15 there.
Yeah.
Thank you.
Okay, now so we've done 30 seconds, inflation. Still some ectopics. I'm not so sure this is wire related. Maybe it's ischemia related rather than anything else because wires are quite back. Right, so we'll just pull this balloon out. Okay, so the next slide, obviously, I'm just going to show you, it's a very important sort of algorithm we use. Well, so we start with the probe bar, then we reassess, and if you have a good result with no significant recoil or no dissection, no flow limit dissection, we go for DCB straight, 1-to-1. We don't need to upsize to any scoring or a cutting balloon. Of course, if you have a recoil, then you have to resort to some of the specialized balloons, and then reassess again. And if you have a persistent recoil, then you may have to go for a stent. Same with the dissection. If it's a type A or type B, non-flow limiting, so you can accept and go for a DCB. However, if you have a nasty dissection with flow compromise, you have to go for stenting. So this is, I'm going to show you what we did here with the...
We've got a nitrate effect on the blood pressure there.
Yeah. So we give some nitrates and we take the picture. As you said, it's grown, huh? It's amazing. So you see there is a excellent POBA result, which means no significant recall, maybe less than, 15%, we think, in the PLV, and no flow limiting dissection. See, we acquired prolonged acquisition to see no dye hang-up, TB3 flow. I think this is ideal placed now to use DCB.
Almost.
So, just most important is when you acquire, you have to acquire till the contrast disappears. So you have to see the contrast clearing, because if you start seeing some dye hang up, that's not a good sign, which means probably dissection may get worse in the future. So you have to keep that eye. So you to acquire till the contrast disappears.
Nitrate effect on the blood pressure.
So I think this is excellent. Look, we're avoiding 2 layers of metal in bifurcation where the vessel is 2.5 and 2.75, and she's diabetic. Although she's not got no renal failure, she's a risk of restenosis with a smaller stent and bifurcation. So when it comes to DCB, you have to go for 1-to-1 balloon to heart ratio, and it should be delivered ideally in 2 minutes to kind of prevent the transit loss of the drug. And you have to inflate to sort of nominal, especially for 1-to-1 sizing. There's no need to go high pressure because you just want the balloon to touch the wall of the artery so that you can diffuse the drug. And we normally keep it for at least 60 seconds, maybe longer. If patients can't tolerate because of the hemodynamic compromise, then you may have to do 2-step inflation. But as I said, you will have ST elevation. But most importantly, once you pre-dilate with a longer inflation, they generally tolerate DCB inflations very well. So, yeah. So, not to touch the shaft. Before I go, there's any questions from the panel before we show the DCB use here? Everyone think that it's ready for DCB now? Bernardo?
I think it's a perfect lesion preparation with a type A dissection, A, B, I don't know, but it's perfect, I would say. Yeah.
Okay, so
Sandeep, when do you use intravascular imaging to be able to optimally size the DCB?
We don't routinely use for sizing the DCB. We use it mainly for lesion preparation. So sometimes if I'm dealing with a very calcified lesion or a fibrotic lesion, if I'm not achieving adequate pre-dilatation with the normal balloons, then I use intravascular imaging to guide whether to go for a cutting balloon or a IVL. But for sizing DCB, I don't use it. I just go by luminography, the QCA.
Mm-hmm.
Yeah, if I may add something, this is a very important point. Differently from drug-eluting stent in a complex setting where you should use imaging before, during, and after to check and do the final assessment, for DCB we usually don't suggest to do it after if you have good angiographic data for 2 reasons. One is that we have a huge experience with angiographic lesion preparation, angiographic data for lesion preparation. 2 is that you would increase too much the risk of bailout stenting if you use imaging at that point.
Not to mention, if you use OCT, you can even dissect further the vessel because of contrast injection.
Mm-hmm.
Yes.
Yeah. Okay, so we took a long DCB, so 2.5 by 40. Where the drug is. So we have to come out like this and not touch, go all the way. Now this is a point where we have to ensure we have to get this delivered in ideally 2 minutes, they say, but this will be delivered in 30 seconds. I'm very confident. I'll check my wire position, so make sure everything's corrected. So my colleague's holding the wire. I'm holding the other wire now, and 3, 2, 1, go. Let's go. So we've gone there, and we deliver this fairly quickly. So my colleague's going to connect it to negative. So this is coming out. I'm hoping there'll be no resistance. You could see the balloons fly through nicely into the PLV. That's perfect. So what do you think, Gabe? That's a good position? A bit more forward?
I think you can go over the hump.
A little bit, yeah. We can always go another way. Okay. Okay, that's perfect. So we'll go, yeah.
So nominal pressure is 6 atmospheres with a MagicTouch.
So we'll go 6 here. It's nicely up. So then we took a second 2.75, so a slightly bigger balloon for the PDA. We took a 30 millimeter. In position. I got the other wire, so I'll go. We're going to go quick.
So these are 60-second inflations.
There's some obviously transit loss. Yeah, so in fact we did 90 seconds. You'll see in a minute. In the interest of time, I just took the support. And I think that's actually right. 2.530 is more than enough because we are well past the. So in fact, go forward a bit more. That's perfect, isn't it? All right, come back everything. Come back a little bit. So, right, that's okay. Do you agree? The stent is, yeah, okay, going up now.
So again, nominal 6 atmospheres.
Okay, timer on, please. Another indication. You see here, this is 1.16, so it's still inflated. 2, there's a bit of ischemic conditioning. That's amazing. So interesting was, in this case, I just pause it, when we inflated the balloon, she didn't have any ST elevation until 50th second. Because we had done that sort of conditioning. So when we were doing a pre-dilatation, within 10-15 seconds, she was getting ST elevation. But when we were using DCB, even when the distal RC was blocked, she didn't have ST elevation until 50th second. So which means she was used to that kind of inflation.
Now that's true. Preconditioning does exist, and it works in the same patient after a few minutes. If you just predilate to keep the balloon inflated for a few times, when you inflate the DCB, you can go longer. That's exact.
Yeah. So, So obviously at this point, I'll take this out. I don't need to give any more nitrates because the blood pressure is okay. So obviously, this is another crucial step post-DCB analysis. Right, so this is where we assess whether we need to do any bailout stenting. So I do a prolonged acquisition.
Well, just to say all ST elevation is resolved.
Yeah, so there is probably some kind of haziness right at the end of the stent. You see that? It's a small, like a dissection.
Yeah, I think there was a little step up in the previous picture.
So, but I think this for me looks great. So we don't know, do I hang up? No. I think one thing we obviously have done with the DCBS, you can comment on, is that we don't take so many injections. We've done one now. We'll wait for another 30 seconds or a minute, and we pull the wire back. So we do that's the last shot because we don't, obviously we want to see there's no distal wire perforation, which we can see here.
Sandeep,
Maybe I can pull the wire back a little.
Here, Sandeep, there is a slight difference on how we deal with this dissection. So I agree with you that this is not a dissection that is particularly worrying me. Okay, it's type B dissection, but usually I wait minimum of 5 to 6 minutes before taking the final shot, to be sure.
Okay. So yeah, I mean, we just took 2 shots here, but you're right. I think if you're concerned about these dissections, maybe you have to wait for 5 minutes and do it again. So yeah, I think it's a very good point. Wait, and then we take one last picture.
And often we do see dissection and it's causing ischemia, so we have to do bailout stenting in that situation.
Yeah.
Sometimes you find progressive recoil, but that doesn't happen immediately. It might be that you wait a few minutes before taking a second acquisition and then see that the recoil has progressed, and that would usually be another reason to put a stent in.
Exactly. Okay, so it's spent like 50 seconds now, so I'm going to pull this back a little bit, the wire, so this wire can be seen. This is the last injection. Again, prolong acquisition till the dye disappears. I think there is some dissection, but again, it's not flow limiting. I think we can accept that.
What would you feel about?
So we stopped here and then we went on to do the circ, which again I'll show you very quickly. I won't take long. This is AP caudal view. You could see there is a disease in the circ extending to the marginal. I think we can leave the AV circ.
There's a lesion on it. I think we've got 2 wires.
Yeah, why not? What we'll do the one. So we'll wire that. So we wired both. We did a NC balloon, again prolonged acquisition, longer balloons. You could see it's 25 millimeter balloon. And this is post POBA. What do you think?
Again, very nice. Play the result. Possibly a little bit of dissection just after the bifurcation in the OM. What do you think?
Yeah, I mean, I think we're acceptable. I think there's a bit of recall there.
There is.
So I think we should take a scoring balloon only to that area, not beyond the bifurcation. Before the bifurcation, maybe take a 275. I don't know whether 275 comes in scoring balloon.
It does, but it may be bigger there.
3.0? So give us a 3.0 by long scoring balloon, please, like a 25 or 20?
It might not come in 25, I think 20.
So then we took a 3.0 scoring balloon, as me and my colleague were discussing. We took I think it was an angiosculpt, so we inflated twice. And this is post-scoring balloon. I would say definitely better. There's still some persistent recoil there. So we were at this stage happy to proceed with DCB again here because remember, this is a diabetic lady. So we don't want to put a long layer of small stents. So we went with the DCB because the lesion preparation was quite good here. So again, we used a long DCB here. So this is very interesting. Have a look at this. This actually didn't deliver as we expected. I'll just play this again. So this was not easy to deliver, but we did a nice trick. I think was something maybe to take home. Failure. It's not going a little bit unexpected. It went a little bit. Maybe it's a wire wrap, do you think? See, at this point, you could do this way. You could take the balloon out, take a guide liner, but then you cannot reinsert the balloon because it's not recommended from any DCB company to reinsert it. So what we did here was, you'll see in a minute, we pulled the balloon back in the guiding catheter, and we took the jailed or the side branch wire out because we are not stenting, you see. So that's a good thing about DCB. So watch here now. So this is not going clearly, so I don't want to lose the balloon drug, so I'll just leave this out here for a second. And I'll try and put the other wire.
And just to mention that the branch that was wired, that we've just taken the wire out of, has been...
And then Side you see the branches, but DCB goes generally- nicely.
Go up to the bifurcation.
You think that's okay? Little test, yeah. So this is going in nicely because there's buddy wire. Yeah, you test and then I'll... Yeah. So then we inflated the DCB again for 90 seconds, and this is the final result. One thing you have to mention is that if you were to treat this with stents, we would have probably put at least 40 millimeter length stent, 40, and then bifurcation, diabetic. I think it's the right thing that we use DCB here. Let's hope that she finds benefit. So we'll pull the wire out now and just leave the wire here. I don't want to completely pull out. And do a last picture. Obviously, this is a prolonged acquisition again. Excellent results. So thank you very much. So we in fact spoke to her because I was asked to present this. So we spoke to her only last week. 19 months since the procedure, she remains well, asymptomatic, no angina. So for me, this case or any case I do with DCB is to minimize the stent length, especially when there are diabetic, renal failure, small vessels, long lesions, where there's an increased risk of stent failure. So for me, DCB angioplasty, especially in some bifurcations and complex lesions, it simplifies the procedure. In this case, you saw we didn't have to worry about the bifurcation. And in regards to technical aspect, I think you saw prolonged POBA is the key, and try and use specialized balloon only if you have recall, not just routinely, because there's no data to support it. And prolonged acquisition post-POBA and DCB to see the dye clearance and assess the TIMI3 flow. And if you have persistent recall or a flow element dissection, go for a bailout stenting. But I would suggest when you do a bailout stenting, rather than covering the entire DCB area, you could just address that area where there's a recoil, focal recoil, or a dissection, rather than covering the whole with a stent. So thank you so much.
That was very instructive, Sandeep. So we have several questions from the audience. I'm going to get your impressions and also some of the wisdom of the panel. The first was in that last case, why did you use a 2.5 DCB after a 3 millimeter scoring balloon?
It's for you.
Sorry.
You did the case, man.
Yeah.
Sandeep.
Why 3 millimeter balloon and use
So why a smaller DCB than the scoring balloon diameter?
Oh, we used a 3.0 scoring balloon, and we used was it 3.0 scoring, 3.0 DCB, no? We used a 3.0 DCB.
It was a 2.5 DCB.
I think it was a 2.5.
Maybe it's a mistake, sorry.
Okay, so that's not something you would routinely...
No. I think it was 1-to-1, sorry.
Okay, so it should be the same as the largest balloon that you use. Okay. Second question is, do you treat coronary dissections differently after DCB as compared to just regular plain old balloon angioplasty?
No, I mean, I think the most important when you have dissection is that you assess the dissection. If there is any flow compromise, then you have to go for stenting. But if there is no flow compromise, even if it's type A or type B, I accept it. Sometimes, if I have a dissection and I don't want to place a stent, I go back with the POBA again with a prolonged inflation. I leave it for 2 minutes. Sometimes that seals the dissection. So yeah.
Okay, and if you choose to defer to a stent because you have contrast retention or the dissection increases with some lumen compromise, you always do spot stenting. And how do you do that in terms of stent size and stent length?
The stent size will be the same as what I would have taken for a DCB, and I tend to take a shorter stent, seal the dissection where its sort of mouth of the dissection is, and then I reassess. If the flow established and its dissection sealed, I'm happy with it, because the last thing I want to do is to cover the entire area with a stent and defeat the purpose of DCB. And same applies for the recoil as well. If the recoil is very focal, I only address that area with a stent.
Okay, so really focal treatment of the area that seems to be undertreated or looks like it's deteriorating.
Yeah.
Next question has to do with bifurcations. That right coronary, obviously both the PLB and the PDA were treated. Is there any concern of corona shifting, and have you ever used a kissing DCB in situations of a bifurcation?
No, I mean, because you're not placing any metal, so for me, the carina shift very rarely happens. Worst come worst I could do is you take a sequential kissing you could do, so you place one DCB in the, let's say, from PD, distal RCA to PLV, you inflate, then you push it forward, leave the balloon there, then you take another DCB, and then you do kissing at the end by pulling them back. I very rarely do it. For me, carina shift rarely happens with the DCB, especially when using in both the limbs.
Okay, and last question is, after you've pre-treated with either scoring balloon or your pre-dilatation in the correct size balloon, if you still have a persistent narrowing of greater than 30%, can you use DCB, or do you just go straight to stenting?
No, I mean, if I've tried all my resort, and if I'm still having persistent recall, then we shouldn't be placing DCB, because it'll probably give you a bad result, an outcome to the patient, to the technology, and the operator. So I tend to put a stent in. So yeah, we just have to accept defeat sometimes and just go for stenting.
Now, if you're treating a dissection, if you have a dissection and you want to touch it up again, let's say, after the DCB, so you put your DCB in and you still see that there's a dissection that in your mind may not be optimal. If you go back and do a post-dilatation after DCB, does that affect in any way the delivery of the drug or the distribution of the drug?
No. Sometimes I've done it. So especially for LAD, diffuse LAD disease, where I've used DCB, and the last thing I want to do is a stent there, because it's preclude lima and everything in the future. I go back with a gentle POBA, leave for 2 to 3 minutes, and then sometimes that has helped me. But if it persists, you just have to put a stent in. But there is no concern post-dilating after the DCB about the drug being dislodged or something. No, it's always in there. So.
Those are very good questions, and I want to thank the audience for submitting those to us. Any other comments from any of the other panel members in terms of how this case was managed?
It is the most important thing, the preparation of the bed preparation. You use the long balloon and at least 20 to 30 seconds prepare the lesion and take the short cine in 2 to 3 views. Yeah. If you're confident, you put the DCB only the delivering the drugs only. So after DCB, I think post-dilation is not important, because before DCB, you should decide what to do. I think it is the most important.
I think that's a good point you made, because the way I always describe DCB is like a painting the wall. So painting is the last bit, but before that you have to fill in all the cracks and everything. So after that, once you're ready to paint, after that, no touch almost, unless you have a dissection or something. I think the most key important is the balloon angioplasty will be very different with DCB than compared with the stent, because you have scaffolding to take care of, the recoil, and you do like quick inflation, quick deflation. So that mindset has to change. When you do DCB, you have to be 25, 30 seconds. Especially when the junior fellows, they are very impatient because they want to inflate, deflate. So you have to make them clean the table or clean the wire or something to give them jobs so that they're engaged doing.
Keep them busy.
Busy, yeah.
Another thing in our center, you usually inflate the balloon 2 minutes, 160 seconds in our center, every cases. So we not inform the ST elevations. We just talk with the patients, issue the patients, please, so we always, every cases.
It's very important to engage the patient. You saw we were talking to the patient. Mm-hmm.
Okay, excellent. We're running a little bit behind, so we're going to move on now to Bernardo Cortese, and he'll talk about the MagicTouch sirolimus DCB and give us an update on its clinical performance.
Okay, thank you. Antonio. Okay, so yes, I will focalize mostly on the last 12 months in terms of publications and presentation of data about MagicTouch DCB. This is the 2-year follow-up of Eastbourne. Eastbourne is so far the largest presented and published study, prospective study on DCB in the coronary arena. And we are showing here a good clinical performance of this sirolimus-coated balloon after 2 years. And here in this slide, I split the indication between ISR and de novo lesions with a TLR which is around 3% in the de novo lesions and 14% at 2 years in the ISR. But interesting is that the fact that there is a very limited late catch-up phenomenon after 1 year. And this is different from other types of DCBs, especially the first generation DCBs, which were showing an increase in the events after 1 year from the enrollment. And all of these events have been adjudicated by a CEC, so it's quite solid data. We already discussed about dissections. We know that leaving a dissection after paclitaxel-coated balloon is safe. We have shown that 10 years ago. Now we have some data also for MagicTouch, and here we can see that the dissections type A and B left after DCB, sirolimus DCB, is not associated with an increase in MI, not associated with an increase in abrupt vessel closure. And we also have this recent publication about the performance of sirolimus-coated balloon in larger vessels. So we have here a cohort of 810 patients, most of them with ISR, which have been treated with sirolimus-coated balloon and which are showing a good clinical performance, again, with a difference in the splat between ISR and de novo indication with this device. And then we have some more data which is important for us to understand how these devices are working. So we know that the paclitaxel-coated balloon, at least those that work well, have an angiographic performance which is better than sirolimus-coated balloon. We have seen this in several studies. With Picoletto 6, we wanted to go with a step forward and understand if there was a difference in terms of physiological performance of this. This is an independent study with an independent core lab, which we presented last year at TCT. We collected information from centers which are experienced in DCB angioplasty. So this is a bias and a limitation of the study. So these results maybe cannot be reproduced in all of the centers. We included only patients with small vessel disease, and the primary endpoint here is a late functional loss, which is the difference between the physiological performance at the end of PCI and the angiographic follow-up after 6 months. This is, as I said, a small vessel disease study, but also a diffuse disease study. You can see here that the lesion length is 24, which is double than other studies like Picoletto 2 or Bello, which included patients with 11, 12 millimeters in lesion length. So here, the average is double than this value. And we have 40% of patients with more than 30 millimeters in lesion length. Length lumen loss is improved with paclitaxel-coated balloon as compared to sirolimus-coated balloon. And here it's negative. So this is also reflecting the experience of the centers enrolling in this study, minus 0.05, with a pretty good performance also in the sirolimus-coated balloon, small vessel disease, 0.10. And then in terms of physiological performance, we have a mu-FR during angiographic follow-up of 0.87 in paclitaxel and 0.85. And again, minus 0.01, 0.03, no significant difference between sirolimus and paclitaxel. So the primary endpoint of non-inferiority between sirolimus-coated balloons and paclitaxel has been met in this study. And importantly, we were also able to identify which is the cutoff of physiological performance just after DCB angioplasty. This cutoff is 0.90, 0.91 for DES, and for the first time we were able to identify this for DCB. So for DCB you can accept a final FFR or derived value of 0.86 or above. If you go below, you have more TLR. If you go above, you are safe, you are good. Also thanks to the late lumen enlargement that you can achieve with DCB. And then we have an indirect comparison between two large prospective registries between paclitaxel-coated balloon and MagicTouch sirolimus-coated balloon. Here we collected information from 2,600 patients with a 1-year follow-up, which has been recently published in CCI, showing no differences, and with a 2-year follow-up, which will be presented here as a late-breaking trial in 2 days from now. Then we have some ongoing important trials with MagicTouch. We have the Magical ISR, the chairman is Martin Leon here. It's a very important study which would like to bring another DCB in the US. Now we only have one paclitaxel-coated balloon with this indication so far, and we want to see if MagicTouch here is superior to POBA with a randomization 2-to-1 with a 5-year follow-up for this study. And the same for the small vessel disease. This study is about to start. I hope that it will start soon. This is a much larger study, 1,600 patients with small vessel disease, centers from the US, also from Europe, with, again, 5-year follow-up. And here the comparison is with drug-eluting stent. But the most important study with this device, and one of the most important studies on DCBs so far, is the Transform 2. Transform 2 is a study with native vessel disease between 2 and 3.5 millimeters in diameter and lesion length up to 50 millimeters, which is enrolling patients and is randomizing patients after lesion preparation between MagicTouch and Xience. The primary endpoint is TLF at 1 year, where we expect a non-inferiority, and the study will go on up to 5 years follow-up with the phone calls, and we want to see if there is also a sequential superiority of DCB as compared to drug-eluting stent, given the effects in terms of TLF that never stop after drug-eluting stent implantation, and which we have shown that they can stop actually after paclitaxel-coated balloon, like we showed in the Andromeda meta-analysis. This is my last slide. These are the centers that are doing a great job. We have here Sandeep, Dr. Moshin, that are enrolling patients in this study. Dr. Moshin, I think you are number 1 or 2 in terms of enrollment in this study. And I'm very happy to share with you that we are very close to finishing the enrollment in this study. Only 49 out of 1,820 patients to go. Thank you for your attention.
So Bernard, I have a question. I mean, you've been a trialist in the world of DCB. When do you think we should compare DCB versus stent, and when we should compare DCB versus DCB, sirolimus versus paclitaxel, for instance? Which situation, anatomical situation, you would design a trial for those specific trial design?
So far, for the DCBs that we have in the market, I don't think that there is a need for a comparison between them, okay, because we already gathered good information about them with all of these studies. You will always have to compare a DCB to a drug-eluting stent. So if there is a new DCB coming into the market, or a DCB that is in the market without a reliable clinical program, I would suggest to compare with drug-eluting stent, which remain the gold standard treatment for de novo.
Mari, for ISR, what would be the ideal study design?
Oh, that's a very interesting question, because we struggle right now. Because we have ongoing trials now in the US where the control arm is just a balloon. It's an unbalanced randomization in the United States. But now with the availability of paclitaxel drug-coated balloons, it creates confusion. Because you have 3 possible controls. You can use a DES, you can use a plain old balloon, or you can use an alternative DCB. So I think it's still problematic right now to correctly design in an ISR a randomized trial, because the control arm is so variable. I mean, frankly, I would probably like to see a sirolimus DCB against what is standard clinical treatment with the available approved options, which would be either POBA, DES, or DCB. So the operator chooses what he thinks he would normally use and uses that as a control arm, and that gets randomized against a sirolimus drug-coated balloon. Mm-hmm. I had a couple of questions for Bernardo. I was struck by the fact that late recurrence seemed to be much more of a phenomenon with ISR than with de novo treatment.
Yes, and we have seen...
And that late recurrence was after a year? Do you
Yes.
think that's due to neoatherosclerosis? Is there something about drug-coated balloons that initiates a neoatherosclerotic reaction in ISR that causes late recurrence? I had never seen that dramatic a difference in the late clinical outcomes comparing de novo versus ISR.
Yeah, so this is not a comparison between de novo and ISR. We just it's a snapshot. But I have to say that DCB is not doing well in ISR. I may be, not very politically correct, but I can tell you that since people do not use imaging in ISR, because in the real world, despite the guidelines, people do not use imaging. In Eastbourne, only 12% of ISR had used imaging. So if you don't use imaging, a DES is always better than a drug-coated balloon for ISR. We have seen in many studies. We have seen also with Science after in the Illumin 4, in the cohort, at 2 years we have less than 10% of TLF. DCB do not work if you don't address the cause for ISR, any type of DCB. I don't know what's going to happen after 1 year if you have recurrent neoatherosclerosis, but for sure in many cases you have not addressed the initial cause for the ISR.
So that's interesting because certainly in the United States, we are assuming that the default therapy for ISR would be drug-coated balloons in most patients.
I'm pessimistic about that.
Okay, well, that's very interesting. Next question I had was on Picoletto 6. Oh, I'm sorry, Antonio, please.
Come here, Antonio.
Yeah, there's room up here, Antonio.
Don't you think that ISR plus DCB is very dependent on appropriate lesion preparation? And the stent is more forgiving. But if you use a DCB, you have to prepare the lesion better. You have to be liberal in using scoring or cutting balloon. And you have also to be willing to cross over to stent the results that are not suboptimal. Because you cannot count on positive remodeling. We always leave suboptimal result in de novo because we pledge on positive remodeling. This pledge in ISR is non-existing.
I fully agree with you. I couldn't have told better.
I have a point, Bernardo, sorry.
So that means, though, if you're going to do ISR and do it optimally, you need to do imaging. You need to do intravascular imaging.
100%.
You need to have the correct size. You need to know that your final result is absolutely optimized.
And if the result is not good, maybe implant a stent or do nothing.
Medical treatment.
Okay, so one other question about Picoletto 6 in the small vessels. It was interesting to me that there was, certainly it appeared that the paclitaxel drug-coated balloon had less late lumen loss. Now, is that because there was more in the way of positive remodeling?
Yes.
I mean, are these two linked? In other words, the so-called improvement from the standpoint of either angiographic restenosis or late lumen loss is only due to the fact that there is more positive remodeling. Because the positive remodeling was very different, 58% versus 40% in Picoletto 6.
Yeah, it's 60% like in other studies. So I think that the negative late lumen loss is related to this positive remodeling, which is much more in paclitaxel as compared to sirolimus. But I want also to emphasize the 0.10 of late lumen loss with sirolimus, which is not there in many other studies.
No, I noticed that. And 0.10 certainly is quite good. Okay, we need to move on because we have our final speaker is, always the most interesting at these meetings, is Antonio Colombo, and he's going to give some sirolimus-coated balloon updates and talking about some of his experience in some interesting coronary indications.
I prepared this talk showing some evidence because we always hear that I think Bernardo gave a nice excursion regarding sirolimus, and I'm going to add more data in this area. If we go back, there is this Fasico study published by the group of Bernardo, small number of patients, 27, but with angiographic follow-up. And you see that follow-up, the lumen gain was quite maintained, and the late lumen loss was very minimal. So these, and we go back to many years. So this is the very first old study that shows that this device does something. Then there is also old study 21, where they compared the 494 dCB rise from EluTax, a small vessel, matched with 596 Eastbourne. EluTax is basically a paclitaxel eluting balloon, and 50% were small vessel. The rest was in-stent restenosis, and you see that the results are very similar. 10%, 10.3, 8.3, 7.9. So it's very consistent effect. And this is another study, same group of Bernardo, more recently, 2020, long-term follow-up after sirolimus-coated balloon used for coronary artery, final results of nano-LUE study, 480 patients, 438 lesions, 183 in-stent restenosis, 185 de novo small, 40 patients with large, 2 years MACE 4.2, cardiac death 0.7, TLR 3.2, MI 0.2. So very, very solid data. We worked with Sandeep, and more recently we published last year use of sirolimus-coated balloon in de novo lesion, long-term clinical outcome, multi-center population, and there were 4 centers. Duration of follow-up quite long, 2016-2022. And we put together 1,360 patients were treated with MagicTouch, big number 771 with de novo lesion, mean age 68 years, diabetic 36% for European studies. This is a large number, insulin dependent 14, and chronic kidney disease 15%, acute coronary syndrome, half of the patient, and there is a considerable amount of big vessels. 22% were larger than 3 millimeter. Lesion longer than 20 millimeter are 76%. So we are really close to a real-world population. Of course, predilatation was universal. We use scoring or cutting in 1/4 of the patient, and 4% rotational atherectomy means that this is a complex subset. And the target vessel MI was 3%, TLR with a follow-up close to 2 years was 6%, MACE rate 8%, so quite encouraging data. So I think the data are accumulating that this device is effective. This is another subset study from Eastbourne, the subset of diabetics. The Eastbourne is a prospective registry with a clinical follow-up. Of course, the diabetic do worse as far as the integer of TLR, 6.5 versus 4.7, but not so bad. In de novo lesion, 2.3 versus 1.6, and we are dealing with a big number of patients, 452, and even not so good, but still not a dramatic difference, basically 9% versus 10.8 in stent restenosis. Here is a more detailed study by a multicenter group, long-term follow-up following sirolimus-coated balloon or drug-eluting stent for treatment of in-stent wrist stenosis. Is a Eastburn MagicTouch compare to DES Dragon study, 1,545 patients, big number, 621 treated with sirolimus-eluting balloon, 1,000 treated with DES, and the results are very similar. In unselected cohort, all-cause death was 6% versus 4.8, MACE 20% versus 17, drug-eluting stent, drug-coated balloon, and TLR 10%, 11%, and the propensity matched basically makes these data stronger, and the two curves are exactly overlap. This is the most recent study, just published 1 month ago, comparing the efficacy of sirolimus and paclitaxel eluting balloon in the treatment of in-stent wrist stenosis. This is a prospective randomized study. Not many patients, but with angiographic follow-up, 72 patients with MagicTouch, 73 with sequence please, high number of diabetics, 44%, 36. This is a mixture of DES ISR and bare metal stent ISR, but 54% with a MagicTouch with diffuse, 27% with a sequence please, and the 12-month angiographic follow-up MLD was 1.85, 1.63. I don't want to say superior because it's a small number of patients, but basically I would say that we are dealing with a similar result, 32%, 36 diameter stenosis, and binary stenosis 30%. There is room for improvement. Here was not routine imaging, no routine scoring, but at least the results are similar. The ESR, the late loss was a little bit better for sequence please, as expected, because again, here you don't have the positive remodeling, 0.7, 0.62, so not a dramatic difference. So I think this is a positive study. And to finish, we are in the corners, but I cannot dismiss the Sirona randomized study for femoral popliteal disease, which is a very nasty territory. The 12 months primary patency with the MagicTouch was 73% versus 75% with the DCB. So maybe we are getting closer to what Bernardo just said before, that we don't need any more comparative study of one versus the other. I skip this about the transform that already was alluded by Bernardo. And I want to finish with the Ginger study, the study that we just completed in Italy, 120%. All undergoing angiographic follow-up is almost completed with 90% angiographic follow-up at 9 months. And this study evaluated in de novo lesions up to 4 millimeter, and many lesions, more than 50%, are in lesion in vessel larger than 3 millimeter, and the lesion by protocol have to be 25 millimeter or longer. So it's a real special subset, and these are the type of lesions that we included in the Ginger study. Here we did PDPA, but it's not a must. This is the type of lesion that we included in this study, long lesion, diffuse disease in area where DS usually do not perform very well. So I would like to conclude that more time is needed. I would say by the end of 25 for more robust conclusion, but preliminary data, I believe, support good clinical effectiveness and especially low side effect and good safety. Thank you.
Thanks, Antonio. That was very, very helpful. And that's a potpourri of data from multiple clinical trials with either late clinical or late angiographic follow-up under various circumstances, randomized comparisons, matched and whatnot, but showing what appeared to be relative equivalence. So, Alex, let me turn it over to you. Are you convinced that the sirolimus and paclitaxel drug-coated balloons in the coronaries are of similar effectiveness?
Very much so, with different mechanisms. I think that I'm very also convinced that we shouldn't be comparing those two devices mechanistically, because they have different mechanisms of action, as you might know. You know, paclitaxel, a little bit more toxic, perhaps promotes a little bit more positive remodeling, and in some cases even a little bit of aneurysm formation, versus sirolimus, which is less toxic. But with the current carriers, I truly believe that there is a biological effect, and probably in the future we're going to be looking more into clinical endpoints as opposed to late loss, for instance, which is not going to be a fair comparison, in my opinion.
Bernardo, any comments?
Yeah, I agree with what Alex is saying. We need the clinical endpoints. We have learned a lot. We need to see the newcomers, the new DCBs that are coming into the market. You know, there is a lot of work for new carriers to, for example, for paclitaxel to reduce the toxic effect on the media, and for sirolimus to help it persisting into the vessel wall for having a good, achieving a good result for the time. So for these probably newcomers, maybe we need to have still mechanistic study with some angiographic data. But I agree with you that late lumen loss is not a good comparison between DES and drug-coated balloon.
Excellent. Well, we're getting to the very end, so I'm going to ask Dirk. Now, unfortunately, Dirk did the first presentations, and he's been forced to sit through coronary after coronary trial, but maybe his perspectives are actually more important. They've had a much longer history with DCB, and it really is embedded in endovascular therapy. So maybe some of your final comments would be instructive to the audience.
Well, Marty, I can say that it was not only an extreme honor for me to be sitting here with, the guys, the heroes of my young career when I was starting in coronaries, like Antonio and yourself and many others. No, it was also extremely interesting to see how now DCB technology seems to change, potentially it seems to change practice patterns also in the coronaries. I mean, in the peripheral, we're always following what's going on in the coronaries. So when you invented stents, we also tried to use stents in peripherals. We had to learn that we have to develop our own materials according to the needs. And then we understood that a lot of metal is not going to be the solution for our long and complex lesions. So the leave nothing behind concept, which was introduced with the DCB, changed our practice, and it's for sure improved the treatment options for peripheral arterial disease patients. So now it's very interesting to see that after many years of the coronary field being very much a DES area, at least my impression was that this was almost a 100% DES area. So now, to see how these new developments help also to provide alternatives for bifurcation lesions, for smaller vessels, in general for complex stenotic lesions. Interestingly, not so much for ISR, as I learned today. But I think there are probably a lot of open questions, but it's very impressive to see how this helps to potentially change practice patterns also in the coronary.
I think we're learning a lot, and I think we're following some of our endovascular colleagues in their long-term use of DCB. I think we're learning how to apply that in the coronaries, and I think that it used to be we talked about full metal jackets. Now we talk, about the term that Antonio had introduced, which is appropriate and spot stenting, maybe better. I will say that for those of you who can find their way to the U.S. for TCT in the fall, there should be 3 major DCB studies presented. One will be presented by Antonio's team, the Ginger trial, which he mentioned, which I think is a key study because it really takes DCB to another level in its really complex native coronary artery disease with angiographic follow-up, which I think will be very provocative. And then there'll be 2 other sirolimus randomized trials, sirolimus drug-coated balloons, one in ISR and the other in 3,000 de novo patients. So we should have much more data with sirolimus drug-coated balloons at TCT as well, and I think that will help us to complete this cycle and help to improve our understanding of some of the subtleties of this therapy. But I want to thank the panel. Their remarks were wonderful, and the audience who were very attentive, and of course the sponsor, Concept Medical, for allowing us to do this symposium and to share some of our observations. Thank you.